All right, I'm Dr. Michael Goldsmith, and today we're going to be talking about cervical disc replacement. It's one of the newest innovations in spine surgery, and I'm going to present this. We'll go over everything we're going to talk about in a second. First, though, I wanted to introduce myself. I'm the Chief of Orthopedics at Sibley Hospital. Kathy Pulford, who is the head of our department, is on the call with us today, too, so she's helping me run through this, and I appreciate, Kathy, all your help on this. My private practice is at Summit Orthopedics, which is in Chevy Chase, Maryland. I'll give you the contact information at the end of the call and talk. I'm also a professor of orthopedics at GW University and work with the residents there, as well as Walter Reed Hospital, and once in a blue moon, the Johns Hopkins residents. And my role as a surgeon, I primarily do neck surgery and low back surgery, anywhere from deformity work, which is like scoliosis, kyphosis, to things like disc replacement, fusions, and laminectomies, or opening up of nerve roots. So without further ado, we will go ahead and start, and feel free to join on as we continue. So let's make sure that this actually, hold on a second. Okay. So why should you care about having a total disc replacement? Well, 65% of everybody in this audience and otherwise will have neck pain in their life and some form of potential radiculopathy, which means arm pain. There's 200,000 neck surgeries done every year in this country, and the majority of those are anterior cervical fusions, which is, by the way, great surgery. People do very well with that. But can we do better? And that's what we're going to talk about tonight. In order to talk about this, these are the different topics we'll go through, both to diagnose neck pain, how people typically present with it, some of the non-surgical treatments, operative treatments, some of the drawbacks of the present surgeries, and then why disc replacement is a good option. So let's move through that. So the majority of problems we see as to why people present to us with neck issues are a disc herniation, which is a piece of soft cartilage popping out of the neck, such as this, and that would hit the nerve root or the spinal cord and present with neck pain or arm pain. People with stenosis, which is narrowing of the canal. So on the left-hand side, we see a nice wide open spinal canal. On the right-hand side, you see thickening of ligaments and disc herniations that causes narrowing on how that travels. And then degenerative disc disease, which is collapse of the disc space with bone spurs and loss of height and loss of cartilage. And then facet arthritis, which is the neck joints in the back of the neck being having a lack of cartilage or bone spurs as well. And that causes a lot of neck pain. So how do people present with this kind of problem that may need surgery on the neck? Typically neck pain, radiculopathy, which is a pinched nerve in the neck with pain going down the arm, or myelopathy. Myelopathy is spinal cord compression that causes gait disturbance or weakness in the arms or legs. It can also cause balance issues and clumsiness. In addition, it can cause loss. It can actually lead to being placed into a wheelchair. The non-operative treatment of neck pain or arm pain are usually just taking Advil or Aleve, which are the NSAIDs. Physical therapy is extremely helpful. And then sometimes we go to oral steroids, which helps to decrease inflammation and pain. We also look at interventional treatments. Those would be things like what's on the picture to the right, which is an epidural steroid injection. Those can diminish inflammation and pain and create a temporary significant relief in neck pain, arm pain, and allow people to get back to a more rapid return of function without surgery. Facet blocks are also injections of cortisone into joints in the back of the neck to help with neck pain. Again, these are all temporary relievers of pain. These are not permanent. And then there's something called radiofrequency ablation. That's burning of the nerve rootlet that goes to the joint. That's only done after a facet block works, if the facet block only works temporarily. And then there's things like acupuncture and non-traditional treatments that can be very effective in neck pain and even arm pain. What about chiropractic care? Well, big red flag there. There's multiple contraindications to chiropractic care when there's neck issues. And these are there because our North American Spine Society has identified that these are risk factors for progression of a neurological deficit through chiropractic care. So don't have it done if you have a disc herniation. If there's fluid in your spinal cord, called myelomalacia. If there's narrowing around the nerves, that's called stenosis. Or if you have a tumor, fracture in the neck, an infection in the neck, and if you have a calcified ligament called OPLL, which is something you probably wouldn't know about, but maybe your surgeon would. That is, hold on one second. Sorry about that. One of those things when you have a Zoom call that happens. All right, to continue. That was fun. So what are the reasons we do surgery for people in their neck, or the operative indications? One is if somebody comes in with a significant neurological deficit. There's really no role, unless the patient can't tolerate surgery, there's no role for non-operative treatment, because if you left somebody with a neurological deficit untreated, they will progress and they will not get better. And then you have somebody who has a permanent deficit. So the issues there are, one, the quicker you do surgery, the less problematic it's going to be moving forward, because you are stopping the progression of a deficit. The quicker you do surgery, the better chance they have of returning to normal strength. So a significant neurological deficit is important. Something that progresses, so it might be a small deficit, but it's getting worse in front of you. That is something that needs to be operated on quickly. Myelopathy, which is spinal cord compression, as we talked about, those symptoms would be balance issues, clumsiness in the hands, gait disturbance. Eventually that leads to loss of bowel or bladder control, and eventually being placed in a wheelchair. So when you have myelopathy, this is a progressive deficit, meaning it will continue to get worse in a stepwise fashion in life. And so once it's diagnosed, it should be treated surgically before it gets worse. And then myelomalacia, which is fluid in the spinal cord. That arrow points to a white dot in the spinal cord. That once you have that, it will lead to myelopathy, and therefore it needs an operation before neurological deficits ensue. And then the most common reason we operate on somebody's neck is because they have continued unacceptable pain despite non-operative care. So what are our options if we operate? First option is called a posterior approach. The second is going from the front, or an anterior approach. So you either go from the back of the neck, the front of the neck, and sometimes we have to go from the back and front of the neck. So posterior surgery, this is much less common. It's probably less than 5%, and in many practices, it's less than 1% of the cases that we do. And we'll talk about the reasons for that in a minute. But there's very limited indications for posterior surgery. One's called a far lateral herniation. That means the herniation is way to the outside. In the low back, if you have a herniated disc, you can literally pull the nerves over, and you can get a disc herniation, whether it's in the middle, in the side, or in the far lateral recess. But in the neck, this is the spinal cord, whereas in the low back, it is not the spinal cord. It is just a bag of nerve roots which can be moved. You cannot touch or move the spinal cord without paralysis. So the only way to get a disc herniation if it's to the side of the spinal cord. The other reasons to do a posterior surgery are called OPLL, which is ossification of the ligament that's in front of the spinal cord. Because if you do that from the front, sometimes you get a dural tear, which is a spinal fluid leak. And then it's stenosis only if there's lordosis, or normal sway in the neck. The problem with that is most people with degeneration in their neck and significant stenosis have a forward flexed neck, or kyphosis, and that is a contraindication of surgery in the back of the neck. And then any posterior pathology like a tumor in the back of the neck. So posterior surgical options are called a laminectomy. That's removing the backbone in the neck. A laminotomy, which is just making a small opening in the bone for opening the nerve root. A laminoplasty, which is what this is. It's cracking the bone and opening it up like a trap door to make more room, which is a little more stable than a laminectomy. And then a posterior spinal fusion, which means you probably are taking away the majority of stabilizing structures like the joints and bone, and then you're putting screws and rods in the back of the neck. So what are the reasons we go in the front of the neck, or anteriorly? These are 98% of the time, again, we go in the front of the neck is because the pathology or the problem is in the front of the neck. This particular picture shows a big disc herniation. So the big black glob to the left of the green arrow is a disc herniation that popped out of place from the center of where it was supposed to be in between the two bones. And it's now hitting the spinal cord, creating what we call myelomalacia, which is the fluid in the spinal cord. The myelomalacia is a sign that the patient needs surgery. So those are two of the indications for surgery. The other are degenerative disc disease. What that looks like are the discs above the big herniation. They're collapsed. They have no cartilage left, and that is called degenerative disc disease. deformity or scoliosis kyphosis in the neck, myelopathy, which is due to cord compression, as we talked about, or narrowing, which is stenosis. Those are all reasons to go in the front of the neck for an operation. The options we have from the front of the neck are called an anterior cervical discectomy and fusion. That's the gold standard traditional surgery we do for the lion's share of people. That's what this picture is. It's basically taking the whole disc out, bringing up the spinal cord and nerve roots, and placing a cage with screws to reconstruct that space and stopping it from moving. It's a phenomenal surgery. The results of it are fantastic. And we'll talk about, however, why there may be some setbacks with that. Other options are corpectomy and fusion. That means removing the whole bone and reconstructing it with a cage and plate, and then a total disc replacement, which we're going to talk about tonight. So the ACDF, or the fusion, is the gold standard. It's an incredibly high rate of success. Patient satisfaction is unbelievably good. It's a quick recovery. It's typically an outpatient surgery for 1 or 2 levels. It's a low complication rate, high satisfaction rate for patients. So why are we talking about anything but that? It's a great surgery. And what's the problem? Will you be left with nothing to talk about because your neck won't hurt? No. The problem with it comes from this study. This gentleman is Dr. Bowman. He's one of the pioneers of modern day spine surgery in the neck. He came up with a landmark study in 1999, which showed that every year about just under 3% of people after a 1-level cervical fusion get arthritis above or below that. So that at 10 years, 1/4 of the patients needed additional surgery, and that's very high. The risk factors for that include surgery at either C5-6 or 6-7, one of those levels, not both. And the reason is 95% of pathology in the neck occurs between those 2 levels. And so if you operate on one of them, the other one breaks down very quickly. If you operate on both of them, turns out the rate of adjacent level arthritis drops to 5%. And so it's actually many times not indicated to operate on the second level, but if there is arthritis at both levels, that's actually a better long-term outcome than just doing one level. And then other risk factors are pre-existing X-ray changes of arthritis. So the possible solution to this is preserve the motion. Instead of taking away the disc and fusing it with bone and cage and screws and rod and plates, putting an artificial disc in place of the disc we removed. So by preserving motion, we can decrease the stress that we put on the level above or below, and therefore decrease the rate of adjacent level arthritis, and therefore decrease the need for additional surgery. So when and how and why do we do total disc replacements? So the reasons we can do it, the indications presently for the present FDA approved implants are 1 or 2 level diseases. So you can have arthritis or herniations or pinched nerves at 1 or 2 levels, but not more. Now, when I say that, that's what the FDA says. It does not mean your surgeon cannot use this off-label. If he or she has a discussion with you about the fact that the way that that implant is being used is off-label and is not FDA approved, but that you and the surgeon decide that that's in your best interest, and you sign an informed consent, you understand the risks of that, you can actually still go ahead and use it for 3 levels or more. But there's no FDA study that demonstrates that that would be effective. That's the problem with it. So we can use it between C3 and C7, which is a lion's share of where pathology is in the neck. However, it is not indicated C7-T1. It typically fails at that level, and so most people would not recommend using it, as the FDA does not approve it either there. The majority of reasons we would do it would be neck and or arm pain with or without a neurological deficit. And you have to have findings of a disc herniation, maybe some osteophytes, and loss of disc height less than 50%. That's a really important thing as we move into contraindications. Contraindications meaning, why shouldn't we do the surgery, or what would lead to a bad outcome? One is that if you use the implants, certain implants are rated for 1 level, other implants are FDA approved for 2 levels. So you really can only do 1 or 2 levels with these implants. If there's a prior fusion above or below the area you are operating on, you should not use this. And the reason is that there's significant increased force that's going to occur through this implant and will probably lead to early failure. If you've had prior surgery at this level, like a posterior fusion or a posterior laminectomy, that would create instability, and it was recommended that that device should not be used. And then if there's anatomical issues with the vertebral body, so if an MRI or X-ray or CAT scan shows that there is an aberrant vertebral body that the implant will not sit properly in and will lead to failure, this should not be used. So it should be normal anatomy, no history of fracture at that level. And finally, and most importantly, if there's facet arthritis, if there's neck pain because there's arthritis in the back of the neck, as this set of CAT scans shows, that patient will not do well with this procedure because those joints will still move. Those joints will still be painful, and that patient will be very unhappy. And there's a number of ways to determine that. One is clinical. I think most physicians who have good clinical acumen can figure that out preoperatively. There's also injection studies that can be done. You can inject those with Marcaine or numbing agent and see if a lot of pain goes away. And if it does go away, that level of pain would be the pain that comes back when the disc replacement is performed. Other contraindications, you don't really need to read through these. These are more for the surgeons to look at. These are not things that patients would know about. So there's some very technical, significant differences between this and a fusion. However, it's interesting, a fusion and disc replacement are pretty much the same surgery. It's the same incision. It's pretty much the same decompression at the beginning. It's just really a different implant that's put in. And then there's a couple nuances where you have to take every single piece of disc out because anything left behind will be an irritant to the nerve or spinal cord. You have to take all bone spurs away. If you do a fusion, you can leave some bone spurs there as they will go away on their own over time. That does not happen with this procedure. You have to completely remove the ligament. No ligament can be left behind. Otherwise, it'll thicken over time and create spinal stenosis or nerve irritation. And you have to be very careful with not disrupting the bone because if it is disrupted, the implant will fail through that disruption of bone. And that's sort of a surgical technical issue. And then there's some other things, again, that you as patients don't need to worry about. But this is what, on a picture, it should look like at the end. You have an implant right in the middle on both the front to back view on the left and the side view on the right. It also shows up that way in an x-ray. And then if you move forward and back, you'll see a total of 7 degrees of motion in all planes, forward, back, side, and rotation. And so it preserves that normal 7-degree motion in all planes. The post-op course is a little easier than the post-op course of a fusion. Just like a 1 or 2 level fusion, it is an outpatient surgery. Patients can wear a soft collar as they want to for 5 to 7 days, but it's not required. Within 3 to 5 days, people are back to work. There's only 6 weeks of restrictions, which is half of that of a fusion. A fusion has 3 months of restrictions. Those restrictions would be no heavy lifting, no running, no jumping, and light cardiovascular fitness can start at 3 weeks and full activity at 6 weeks. And then patients do have to take 6 weeks of a nonsteroidal akin to asthma, and the reason for that is because it decreases the chance for the implant to get stiff, something we called an extra bone formation. So that's important. And then there's a ton of different implants out there. It turns out that the results of them are all pretty much the same. This was the first implant that we ever used, called the Prestige from Medtronic. This is, again, a first generation implant. It is not something we use ever now. It's fixed with screws, which is an okay idea, but not wonderful. And it's got metal on metal articulation, which if anybody reads, lawsuits and things, that metal on metal is not a good thing to use anymore because there are particulate matter that can be created and actually go to the brain and cause some early dementia. So although this was a very good implant and had good results, we don't use it anymore. ProDisc C was the next generation of these. This is the sort of the state-of-the-art one, and these are what most of the implants today are based off of. It has metal end plates, a plastic center core, very similar to, say, a hip or a knee replacement, and it's fixed by these fins in the middle and sprayed with titanium in the end plates. And these are constrained implants that don't move a ton. The next one, which is sort of the present gold standard, is Secure C, which is from Globus, very similar to the Synthes. In fact, most of the people that worked on this came from Synthes, started Globus, and these guys became multi-millionaire billionaires. So you can tell that this has done very well. The Bryan Disc has a slightly different articulation, and that is encased with a plastic sheath around the middle, and they put saline in the middle for a variety of reasons that they think works better. What they really are doing is they're trying to capture any wear particles and maintain them in this sheath. And we don't really know if that works yet. The 10-year data looks the same as all other 10-year data. We would probably know if this is a benefit more at the 15 to 20-year mark. The Mobi CLDR is the one that probably does the most advertising online, so people have seen this the most, but you know, the only difference here is that the fixation is laterally, the fins are off to the side instead of the middle, and it works well. It is approved for 2 levels, but that was the first one approved for 2 levels, but there are a number of discs now that can be done at 2 levels. So what are the results of these? Well, overall, the neck motion is better, and that's what their implicit idea was let's improve neck range of motion so that it decreases the chance for problems above or below. And that is what happens in all the studies looked at, both in models as well as with patients. What happens at the adjacent level? Well, it turns out in a fusion, there's increased range of motion, which is bad. We want the motion to be at the level of the surgery in, say, a disc replacement. So when you look at disc replacements versus fusions, the range of motion at the level above is higher in fusion patients, as expected, and that's why they break down. What about pain and function? Well, the results of a fusion are so phenomenal. You are not going to see a difference at 1 year, 2 years, 4 years, maybe not even at 10 years in the results of how people feel. The results are the exact same, which is good. And that's what they're really looking for. They're looking for similarity in results. They're making sure that it's not worse. So the results are the same over all the different models versus a fusion. What about the rate of X-ray changes? So that means we look at an X-ray, doesn't matter what patients are complaining of, maybe they have no pain, usually they don't. Are there changes above or below the implant that show arthritis? And that 2-year and 4-year data shows that in a cervical disc replacement, it is better than a fusion. And most importantly, and this is really what surgeons and what patients should care about the most, what is the reoperation rate of a fusion versus a disc replacement? Well, the 2-year, 4-year, and 10-year data all have a tendency or a trend towards improvement of reoperation rate in the disc replacement patients. Now, there was not a statistically significant difference, but if you look at the numbers make, it just happens to be that they didn't have enough patients in these population studies to show a statistically significant difference, but it's a tendency towards improvement at every time frame. For instance, at 10 years on the Bryan study, 16% of fusion patients needed a reoperation, whereas only 9.7 or just over half of patients needed it in the disc replacement. That's all comers. And that's really what it looks like at most time points. We don't have things past 10-year data because it's too new. We've only been using it for 10 years and studying it for 10 years. I can tell you my patient population, I've done them for about 11 years, and I have not had to revise one yet. So I think the data is good. And my patient, I'm very restrictive in who I pick because anybody with those osteophytes in the back of the neck, arthritis and facet joints, we do not do surgery on them because they're very unhappy in studies. And even though patients may push for it, very restrictive. If you use very strict criteria, patients do very well with this surgery. So there's this thing called the Cochrane review, which we as surgeons look at, and that looks at all different studies and takes away the bias. And basically it says that when you look at the randomized controlled trials, which are the RCTs, level 1 evidence, which is the highest level of evidence, a total disc replacement is better than a fusion for all primary comparisons. So that's good news. So a quick case, and then we're going to go to questions. So this is just informative so that people can say, well, it's sort of like a friend of mine or myself, and makes sense to do it. So this was a patient of mine who's a 42-year-old IT consultant, lives locally, had a history of neck and left arm pain. The imaging demonstrated a disc osteophyte complex at C5-6 with C6 radiculopathy. There was some loss of height of 5-6, and he had some early myelopathic changes. He had undergone non-operative treatment without improvement. This is a set of x-rays, and you can see if you count down the top vertebra is 2, you count down to 5-6, there's about just under a 50% loss of height of C5-6. He's at 4 millimeters instead of 7. This is the MRI demonstrating a herniated disc, an osteophyte or bone spur at the C5-6 level on the left-hand side, which means that's the side of the pain. It was consistent with his pain patterns. And then we did this procedure, which is, if it transmits well on your screen, we removed the disc, took away all bone spurs, and reconstructed it with a device that continues to move. This is the Globus device. And it shows a very nice midline placement of the device, and this patient is like 9 years out and doing fine. There's the 1-year post-op and motion on flexion extension can be seen and no displacement of the implant. So in conclusion, this surgery is a very good alternative for 1 and possibly 2-level disease. It's got comparable pain relief and function to a cervical fusion, and it's got a lower reoperation rate than 2 years, 4 years, and 10 years. And then our long-term results, we'll have to see. So thank you very much. I want to thank the Gildenhorn Institute for allowing me for this platform. They're the ones who sponsor this and have sponsored our orthopedic care at Sibley. I also want to thank Kathy Pulford, of course, who puts all this together. And if there are any questions, we will take a look at the Q&A, if I can do that, and we'll see what people say. All right. So I can read through these. I will read the questions, read the answers. So when did ProDisc C come out? That came out about 11 years ago. And that was, that's the Synthes disc. It's sort of the second generation, really one of the best disc replacements out there. Still utilized today by most physicians. Some of us have progressed to a couple different implants, but I think the results speak for themselves. They're excellent results. So then there's a question, you advise against chiropractors. How about physical therapists? So I don't advise against chiropractors. I actually think chiropractors serve an excellent aspect of care for our patients. I just advised against them for certain diagnoses that I reviewed, and that would include a disc herniation, myelopathy, pressed nerve or spinal cord, because by manipulating somebody's neck, that can increase the nerve or cord compression, and that can lead to a significant adverse outcome. So, but there's still a huge role for chiropractic care in patients with neck and low back pain who don't have those contraindications. Physical, and then they ask, what about physical therapy? Therapy, as I put in there, is one of the very important aspects of non-operative care. It is not indicated for somebody with a progressive neurological deficit or myelopathy. Those are surgical problems, but for patients with neck pain without weakness, it is a very important aspect of care. And for many people, combining that with an anti-inflammatory is the treatment of choice. Most people do not need surgery on their neck. I would say that, therapy is really one of the most important aspects of care there. So then there's somebody with like 7 questions. These are great. I love it. All right. So long-term consequences of multi-level fusion. The biggest one is adjacent level disease. It turns out it's not even multi-level. It's one level. One level is the worst outcome as far as adjacent level degeneration. That's 25% at 10 years. 2 levels drops down to 5%. We do not have a lot of data on multi-level 3 and 4 fusions, but of course, those do create stress at the levels above. When we're doing 3 and 4 level fusion, that is typically for a neurological problem, and there's really no way around it. So you're doing surgery. You have some downsides to these surgeries sometimes that you have to accept, but you're doing it and saving somebody's spinal cord, so you have to sort of go along with that. I'm going to go back. let me go back to the first question because I missed that. I'm still trying to understand the difference between fusion and disc replacement. For fusion, isn't the disc removed and replaced? And TDR, how is the stability obtained? So they're exactly the same surgery from the beginning until you put an implant in. You approach the neck usually for my procedures, I approach the neck from the left-hand side. That decreases the chance for hoarseness. And protects the nerve called the recurrent laryngeal nerve. We do it through a minimally invasive muscle-sparing approach. No muscle is cut in this surgery. Very little blood loss occurs in both surgeries. We dissect down through a bloodless intramuscular plane to the front of the neck. We then take the disc out, also the ligament in front and in back of the neck, disc space that is. We take all bone spurs out. And then at that point, you're done with the decompression. Then you move to either the fusion, which is implanting a device that doesn't move, or the disc replacement, which is implanting a device that does move. And that's the difference. The stability of the implant depends on the implant you're using. For a fusion device, the stability is obtained by putting screws in or a plate over it with screws in the plate. The stability of a disc replacement occurs by ingrowth. So there's a fin above it and a fin below it. So there's this disc, a fin above, a fin below. It's put into the disc like I showed on the picture. And those fins hold it in place, and bone grows into that and into the end plates of the sintered titanium, or whatever the end plate of choice is for the implant. And so they're both very stable implants, so neither one are going to go anywhere. All right, coming through. How about, what does it mean when you have shoulder and arm pain starting in about October? I don't know. If it starts in October versus November, I'm not sure the difference, and it lasts a few months and then goes away. So it's very hard to know without a physical examination what shoulder and arm pain is. It can be from a pinched nerve in the neck. It can be muscular. It can be from your shoulder. It may be radiating up from your elbow. So the most important thing is to get in to see a physician for an evaluation when that pain is symptomatic, and if you feel it needs treatment, and then that diagnosis can be made by your orthopedic surgeon and then treated appropriately. All right, best type of pillow. So I get this question a lot. And I should go into selling mattresses, by the way. Mattresses and pillows, I could be retired by now. So mattresses and pillows. For mattresses, I tell people firm mattress, but check them out, try them out. They should be comfortable for you so that you can sleep. But firm is better than not firm. As far as pillows, up to you guys. That's a dealer's choice. Typically, if you do have a pinched nerve, you want to have something where your neck is not bent all the way back or extended, because that will pinch the nerve further. And maybe have a little bit of flexion forward, but not too far forward. But again, it's more of a comfort thing. So that is what I would say to do. As far as, all right, I'm going to read through a couple more of these. Can a ACDF be reversed? Well, if you have a fusion, and the problem is if you have a fusion, you take that fusion down, not only, and try to replace that with a motion device, what happens is the back of the neck, where you have not had an operation, is already really also fused down. Those joints have become stiff and most likely auto-fused. So even if you replace the front of the neck with something that moved, the back of the neck would not move. So it really wouldn't work. So we don't espouse that it wouldn't be a benefit to anybody. If you have a solid fusion, I would just not think about ever having surgery at that level again. But we do sometimes address a fusion and redo it if there's a pseudoarthrosis. That means if it didn't heal all the way, or if it fused in a flex position and the patient had severe kyphosis or flexion through it, and we needed to correct that, then you can re-break the fusion. But you wouldn't put a motion device in it. You would just put a better implant or a more appropriate sized implant to correct the deformity. What is adjacent level disease? Well, we talked about that. That's what, arthritis above the fusion. And treatments are all the treatments for the primary disease, the same thing. Any harmful effects from long-term steroid use? Yeah, so not really. If oral steroids, more so than epidurals. Epidurals, if you limit it to 3 epidurals a year, you should have no significant side effects from that. Oral steroids, really a Medrol pack maybe every 2 or 3 years would limit your long-term side effects from steroids. Success rate for artificial disc replacement, we put that in the talk. Do surgical and non-surgical protocols regarding cervical issues have the same results long-term? No. I mean, again, it really depends. So, again, that's a very difficult question to answer, but you have to think about what the indications for surgery are. Okay, the surgery indications are typically a neurological deficit that's profound or progressive. So if you take that diagnosis and you say, what are the results of surgery versus non-surgical treatment? The results of non-surgical treatment are deplorable and are much worse long-term. So it's not even close, because you will get, without surgery, you'll get a progressive and permanent deficit. With surgery, you stop the progression and potentially, most of the times, get improvement in your neurological function. What about the diagnosis of just arm pain without deficits? Well, we don't recommend immediate surgery for the neck for just arm pain without a deficit. we would recommend non-operative treatment for anywhere from 6 weeks or more. And if there's a failure or inability to control that pain, that then becomes the patient's choice without a deficit. The choice is, would you prefer to live with the pain for longer without a potential known time that that's going to stop, or would you like to solve the problem now and move on? As far as with those patients for radicular pain without weakness, at all time frames at 1 month, 6 months, 1 year, the surgery is better than non-operative treatment. At 4 years, it's still better, but there's a tendency towards getting it closer. At 10 years, it's about the same. So I guess you'd have to say to yourself, can you live with the pain for 4 years or more? Because eventually it might go away. As far as the diagnosis of just neck pain, it's a pretty much similar concept. Surgery is better at 1 month, 6 months, 1 year, and then a tendency at 4 years to be better, but not statistically significant at 4 years. But the reason, and again, why do you have cervical surgery? The indications and the reasons for a neurological deficit that's profound or progressive, or for pain that you're no longer happy with living with. And that third reason is really very patient dependent. Everybody has a bit of a breaking point for when they're really not happy to live with the pain anymore. And so that is a discussion between surgeon and patient. And really, when it's a quality of life issue, when you can't work anymore, you can't enjoy your sports, your family, day-to-day living, that's an indication that you've tried everything else, including therapy, medications, potentially injections, and it's very reasonable to move forward with surgical intervention. Let me see if we have any other questions. And okay, so once again, thanks for coming tonight. Thank you to the Gildenhorn Institute. We try to keep these to 40 minutes, so we're just about 3 minutes off of that. My contact information is there if there's any further questions. If you have a problem in the cervical spine or lumbar spine and need it evaluated, I'm always happy to try to work patients in. And if you're ever around Sibley Hospital after COVID ends and you want to say hi to me, I'm typically there every day as the chief of orthopedics, trying to make things right for the patients, and Kathy's just trying to keep me straight. But thanks again, and I appreciate everybody being on. We will talk soon. Take care.